There we go. All right, should I just get started, or? Yeah, okay. So we've got all that there. Recorded, yes, good. Okay, so this is a lecture that I actually just gave recently at the Southern California Emergency Care Conference. And so that's a conference that's mainly directed at medics, nurses, and people in and physicians in pre-hospital EMS care. And so the title of that was on what can we diagnose with an EKG. This is the first issue is to go over the objectives. An EKG is, just think of it like a musical instrument. It's only as good as it's played. And so if my daughter's just learning how to play trumpet now, so when I listen to her practice, I play, other songs for her, so she really likes actually listening to Miles Davis. So she gets to hear what the trumpet can sound like. And so, and you realize that with an EKG, just like a musical instrument like that, that because it can be played poorly, you have to really think, we don't really take that much time to think about, well, who plays it well? And the assumption is that we all play it well. And the data is that most of us play it really poorly. And I'm going to share some of that data with you and go through some articles that kind of demonstrate that. But I think just like any other instrument, the important thing is to learn from the mistakes, right? And so what you can do with an EKG is you can play the wrong key, so to speak. You can make mistakes on purpose with the EKG, and the benefit of doing that is it helps you actually understand it better. So I generally tell everybody, if you're working with EKGs, you're looking at EKGs, just play with it for a while and mess it up on purpose. And so that when you do, you'll begin to understand why that's not playing right, and what's wrong with it, and how to recognize when it's not being done right. Because that's the most difficult part of this. And especially for those of us that are reviewing EKGs that are in the pre-hospital field, is I can't see how the EKG was applied. All I get is the output. And from that output, I have to then determine, can I make sense of this EKG? Can I diagnose with it or not? And there's a big difference between that. We throw these terms of diagnosis around all the time, and what diagnosis means to me as a clinician is different than what it means to me as a scientist. And as a scientist, a diagnostic event occurs when I have sufficient data that is reliably accurate to make an opinion about that's there and that I have proof of, right? So most of our patients that we see in the emergency room don't move out of the emergency room in any particular direction with a diagnosis. And so if you ever actually look at my notes, I don't have a diagnosis line in my review of patients. Instead, I've replaced that with clinical impression. And that's for two reasons. One, it's more intellectually honest to list what your clinical impression is. And second, it's more defensible to list what your clinical impression is. So therefore, you're technically not making a misdiagnosis. You're not closing the diagnostic loop on somebody by saying this is their diagnosis. And that applies to even conditions like this where a patient comes in with a STEMI, right? My clinical impression is a STEMI. If you look back through my experience, you'll find that I have patients who came in with STEMIs, right ventricular infarct, who then get admitted up to the cath lab to find out that they have an aortic dissection that's dissecting through the coronary artery. Yes, they're having a STEMI, but the underlying diagnosis is an acute aortic dissection. And so most EKGs and most bedside devices that are used right now are either performed poorly so they lose their diagnostic qualities, or they're not set up to be a diagnostic instrument. So the bedside monitors that we have right now are not diagnostic instruments. And the reason they're not is that we define the ability to make a diagnosis with an EKG as having a 12-lead EKG at least. And the bedside devices have 3 leads or 5 leads attached to a patient. Therefore, by definition, they're not diagnostic. And then the reason we're putting them on the patient is to identify arrhythmias, right? So they're all arrhythmia monitors is really what they are. They're not a diagnostic monitor. There's a device, a software actually, that was invented by Philips called EasyNet. And it's used in ICUs, and it uses 5 leads. And then based on those 5 leads, it interpolates where the other lead positions would be and uses a complex algorithm to vector what the other portions of the EKG would look like to try to provide a 12 lead at any time from the bed in the ICU. The problem is that those imputations and forecasts are inaccurate, and so they never got FDA approval to actually use it as a diagnostic instrument. So instead, what it is an early warning system to basically say, hey, get a real 12-lead EKG on these patients. And so that's really kind of the big difference between what's diagnostic and then everything else that's truly surveillance. And so the key thing is that if we perform an EKG correctly and understand the basic principles of diagnostic EKG acquisition, then we'll actually be working with good data. And if you got good data in, then you can get something out of it. If you got garbage in, then you get garbage out, right? So we'll look at recognizing patterns that diagnose specific conditions. Hopefully you have an improved ability to read and determine a good EKG following this. And to also just enjoy this run through, don't worry if it doesn't all make perfect sense. I have to repeat this learning myself over and over and over again just to try to keep current with it and stay confident. So it just, like any instrument, it takes a lot of practice. This is one of the few lectures I give where I have to give you disclosures. I've got multiple patents and patents that are pending in novel technology of diagnostic EKG space, co-founder of C-Booth Innovations, the company developing and marketing a series of EKG devices for clinical and consumer use. But the topic of diagnostic EKG is focusing on clinical interpretation of existing technology, and it's unrelated to any of the above potential conflicts. And then there's just the admission that sometimes I do stupid things. And so I don't know if this is going to play. It may not. Oh, it's not playing. Sorry. So anyway, the brief backstory to this is we were recording a sound of a defibrillator, and I needed to we were in a simulation lab, and the simulation, it's a real defibrillator, but it's hooked up to a dummy. And so, and it's going to again. Anyway, so I had to disassemble it and put it in active mode to be able to get it to make the sound. Otherwise, it doesn't make the sound of the actual defibrillation coming across. And so Dunphy agreed to be my test subject. And so it's really unfortunate that, let me see if I can get that to play one more time. It's not going to. I'll show it to you later. Anyway, the long and short of it is that we were arguing before I'm about to do this of how many joules to give them. And I'm being conservative, so I'm like, I'm going to give you 1 joule because you can set the monitor for neonates. And he's like, oh, let's do 10. And that's the face he actually made after hitting him with 1 joule.
1 joule.
So that's 1 joule of him like jerking back in the other direction. So the live video is much funner. So, but while we were in the simulation lab, we had a very experienced paramedic, and we asked the paramedic to apply 12-lead EKG as quickly as possible to the mannequin.
That's his place.
And so those were the placements. And so you'll notice that the right arm and right left leads are up high on the chest and then on the torso. That where V1 would be is actually on the sternum rather than to the side of the sternum, that V2 isn't on the other side of the sternum, and that the left leg is like left upper quadrant, and so on and so forth. The right leg, this is one of the interesting things. And so anybody that does an EKG, I'll just tell you right off the bat here, you can save yourself 1 step. you don't have to put the right leg on a patient. That lead doesn't do anything. There's no measurement from it. It's a ground.
Yep.
So whether it's on the patient, not on the patient, doesn't matter. So technically, we just saved you 10% of your time by doing EKGs. So by that alone, 10% saved, right? If you look more closely at that, you realize that V5 was placed here, and V1 lead is over there, right? And here is the left lower leg that was up in the left upper quadrant. So there are a number of errors that we're seeing here. We have both inadequate positioning of the leads, right? And we have lead transposition. And so this happens all the time. And so this is this wasn't to embarrass the person that did this, just that they've got over 20 years of experience of being in the field, and they're a good paramedic. Saved a ton of lives. I've seen their work, great work. Just this was applied poorly. And so that brings us to an article looking at the accuracy and ECG lead placement among technicians, nurses, general physicians, and cardiologists. And this was a study out of Chelsea and Westminster Hospital, which is a really good hospital in London. So we're not pulling this out of the boondocks. This is a legit place. And what they did is they wanted to determine the reliability of ECG precordial electrode placements by the doctors and nurses involved in emergency care. And so they had 120 subjects were recruited within 2 days from 6 hospitals. They comprised physicians, nurses, cardiac technicians, and they were asked to complete a questionnaire and marked on 2 diagrams of the chest wall the positions they would place precordial electrodes, V1 through V6. Right, so this isn't even all of them. This is just the precordial leads. And the study showed a lot of differences. And the interesting thing was that the correct position of V1 in the 4th right intercostal space was identified by 90% of cardiac technicians. So that's the cardiac technicians are equivalent to our EMTs. But only 49% of the nurses, right? And then only 31% of the physicians. But that was excluding the cardiologists, because when the cardiologists were looked at specifically, they got it right 16% of the time.
Wow.
Right? And so who's playing the instrument the most?
Techs.
The techs, right? So you so just think of that as the trumpet. You're passing the trumpet around, right? And you're in a band, right? And you give it to the trumpet players, and like 90% of them play it pretty well, all right? There's always 10% of anybody that does just, they're faking it, like they're just holding it, right? But the other, right, and then you pass it around the rest of your bandmates, right, and you give it to the drummers, and the drummers are like, 16%. Only the opposite issue is that it would really be like giving it to the person who's conducting the band and realizing that the person conducting doesn't really know how to use the instrument, right? And it's because they don't practice with it. They interpret them left and right, but they don't actually go through the physical process of laying them down. And it begins to put into context what we saw here, right? So this isn't an egregious error. This is in the ballpark of cardiologists. And so it's important to realize just how inaccurate these are placed. This was a good study out of the African Journal of Emergency Medicine, and this is published by Lynch. And there's some important things to consider. The African Journal of Emergency Medicine is not the top-tier journal in emergency care, but it's a very relevant journal for a number of different issues. And the first thing to recognize is that it's generally coming from a continent in which medical resources are severely limited. And decision-making has to be absolutely clear because you have limited resources. So if you're going to treat somebody who has a STEMI in certain parts of Africa, you're not going to have a cath lab to send them to. And you're only going to have an expensive dose of thrombolytic agents to use, and not many of them. So the pressure's on to get it right. And so this is an EKG that they demonstrated where there was evidence of ST elevation in leads 1, leads 2, and slightly in lead 3 too. So the interpretation was an acute STEMI in the inferior and lateral leads. And you can see ST elevations in V5 and V6 as well there. So you have an inferior lateral STEMI, and the doctor was getting ready to push fibrinolytic, and this was a junior physician. So the junior physician showed the EKG to a senior physician, and the senior physician said, hold on a second. And looking at this EKG, said, there's a lot of things about this EKG that don't make sense. I think we might have something wrong here. So let's go back over to the bedside and repeat the EKG. And so they go ahead and they repeat the EKG, and that's it there. So very little time has passed. The patient was having shortness of breath, but otherwise that was it. And they looked carefully, and there are no longer ST elevations in leads 2 or AVF or in V5 or in V6. And they realized that what was occurring was that there were a number of transpositions of the lines, that they had transposed a right arm and a left arm. They had transposed a few other leads, because generally if you get the arm leads and the limb leads on incorrectly, you'll create certain patterns, but those patterns are generally going to only affect leads 1, 2, 3, AVR, AVL, and AVF. They shouldn't affect the precordial leads. And the reason that has to do with that is that there's what's called the Wilson common terminal, where basically the limb leads all create like a circle around the patient, and so that has the same, more or less the same radius to the chest, because the same distance from the heart, more or less, and they cancel each other out, and they are the ground for the precordial leads. So if you put the limb leads all really close together on the chest, you can kind of play with what the amplitude is on the precordial leads, but in general, the pattern of the precordial leads will still be maintained. And so the only way to mess up the precordial leads is to transpose those leads from each other, like we saw V5 in the wrong position for V1. And I'll go back to this again briefly. You'll see that there's colors there, right? Every EKG is color-coded, and that's internationally done pretty much the same colors. There may be one switch in the colors for European compared to US, but in general it's the same colors. And the leads are described the same, except for in Europe, instead of V1 leads, they're C leads. So it's C1, C2 through C6. So if you're ever abroad and you're trying to get an EKG on somebody, just the C's and B's interchange with each other. So they see this, and then they compared the two, and he said, look at the differences here. Lead 1 is inverted, and lead 2 is inverted from what it should be. And then we kind of see the same thing for AVR, and AVF also is inverted here. And then you'll see here in the precordial leads that you don't actually see a progression of the R waves like you should. You generally should see S waves in V1 progressing to R waves in V3, V4, getting bigger by V5 and V6. And that whole pattern's messed up. And whereas you see that restored now with the repeat EKG. And they investigated this even further and found that it was actually attached. This was how it was attached to the patient, and the color codes were all off on here. So you see where C1 should be red, and we got a blue dot there. Right should be orange, and now we have black there. So the instrument itself is actually put together incorrectly, and this is what it looks like when you actually put it together right. Mm. So how do we do this? This is the classic Einthoven's triangle. This is what's used to how we interpret the limb leads, right? And the limb leads are called limb leads because guess where they go? On the limbs, right? Not on the torso. They're put on the torso during exercise stress tests as a compromise, where placing leads out on the limbs while you're asking somebody to move their arms can create a lot of motion artifact, and so it's difficult to interpret the ST segments, and so they agreed that, okay, for stress tests, you can put them on the torso, but there's a lot of variation when you're doing that, and it's not diagnostic. In fact, I've done this experiment myself, but there's literature on this as well, that if you put the limb leads even on the upper shoulder, it misdiagnoses the frequency of inferior STEMIs considerably by up to 20%.
I need my EMT.
And so you need to put them just south of the shoulder. They don't have to go on the wrist, but they just need to go south of the shoulder joint. And the lower limb needs to go just south of the hip joint. There is some data that suggests that there's less variation by putting it on the very lower quadrant of your abdomen, but for technical purposes and really for diagnostic purposes, below the hip joint is where it needs to be. So it's really not that difficult to get that little bit further. And so that's the first part of just like, how do you get the limb leads right? You got to get that part right first. And then we look at the way the limb leads are done, right? So the leads are applied, but rather the electrodes are applied, and a lead is defined as a bipolar event, meaning there's a negative and a positive between those two. And you can reverse all of these, right? So you just have one electrode and you decide, well, which direction is the negative and which one's the positive. So in lead 1, the negative is in the right arm and the positive is in the left arm. So, and your heart is not in your chest in an equal right and left way like your hands are, right? And your right and left ventricles aren't mirror images either. It's like having a baby hand on one side and an adult hand on the other. And so that right hand and that heart is rotated in your chest so that if you were to stab somebody in the chest this way, you're going to hit the right ventricle because the right side is turned like this. And the left side's here. And like I said, they're not similar sized ventricles. The right ventricle is considerably thinner than the left ventricle. So in terms of mass and amount of electricity that's generated from the right, it's less than that from the left. And so the majority of the signal should pull towards the left, right? So if you just think about looking at a person's heart and imagining an electrical strike occurring, most of that electrical strike is on the left side of the heart, right? So if I'm like here, from your view. And that strike that's occurring is what you're recording on the EKG. So just keep that visual in mind of that's mainly a left-sided strike, right? So now, if your right hand is negative and your left hand is positive, and the strike is left-handed going to the positive, what direction should the signal move? Should be moving towards that direction, right? So as long as it's moving that direction towards the positive, it's going to have a positive deflection. And lead 1 will have an upgoing R wave, because that's where the majority of the ventricle is contracted during that time, right? So there's that. Lead 2, the positive is actually down the left leg. The upper chambers of the heart are much smaller than the lower chambers of the heart. So where's that sound loud? Where's that strike loudest? At the lower portion, right? Going towards the left leg. So that deflection should be towards the positive lead. So it should be upright. Lead 3, the negative is now the left arm. The positive is the left leg. And again, it should be slightly positive. The reason why it's less positive than the other is that you're on the left side of the heart and the majority of that side is firing. So you're only picking up the subtle differences between the upper and lower portions of the heart, but you're on the same side. So if you have two people on the same side of an event, looking at an event, they both give you pretty much the same signal. So this is where in lead 3, the signal tends to be isoelectric. Isoelectric meaning that the amount of electricity on the positive side is balanced by the amount on the negative side. It doesn't mean that it's a flat line. It just means that if you were to measure how much electricity is moving towards you, it should be in a normal EKG, it should be slightly more positive than the amount of negative that's there. Then, AVF, AVL, and AVR are not isolating one lead from another, but actually using 2 leads as a negative and 1 lead as positive. And the easy way to remember that is in AVR, the positive is right. In AVL, the positive is left. And AVF, the positive is the left leg. And the other 2 are used as your ground. So now, when you start to think about how the positive deflection in 2 is towards the left leg, right? The positive in lead 3 is towards the left leg. The positive in AVF is towards the left leg. And those represent the lower portion of the heart. So if you have an ST elevation in 2, 3, and AVF, that's an inferior infarct. Makes sense because you're looking at it from that perspective. And I often explain to patients that when we're looking at an EKG, it is like taking 12 snapshots of walking around a 4-bedroom house where you have 2 rooms upstairs and 2 rooms downstairs. And the 2 rooms upstairs are much smaller than the 2 rooms downstairs. And the left room's bigger, right? So, but we're walking around a heart from different perspectives, looking to see which room is there a fire burning in. And that's what we're trying to identify. And this is how you know to remember that what's diagnostic about a 12 lead and why is a 3 lead and a 5 lead not diagnostic? Because you're not walking around the entire heart. The 12 lead technically isn't walking around the entire heart because you need to consider posterior infarcts and then also right ventricular infarcts. So this is where you have 15 lead and 18 lead EKGs. And most of the devices come with extra wires to actually do 15 leads and 18 leads, but we don't apply them for many practical reasons, mostly being it takes much longer to do that. So again, that's kind of what the forces are. So within AVL, because you're using again that left leg and that right leg the left leg and the right arm as negatives, and they're moving up towards the positive here, AVL tends to be still somewhat left-sided, so still tends to be somewhat of a positive deflection. That's what we expect there to be in AVL. But that can be mitigated slightly by the right arm because the left leg and the left arm are, again, seeing the same side. They're just being mitigated by the right side a little bit. And then AVR, you expect it to be downgoing because now your perspective is opposite, and so we expect it to be a negative deflection. And I've seen this over and over again in clinicians who have, even cardiologists have said this to me before, that AVR is just the exact opposite of lead 2. And it's like, nah, you don't know, you don't understand vectors if you say that, right? Like that's not the case. It's not the exact opposite because they have different polarities that are influenced by how they're done. One's a dual negative and the other one's a single negative, and it gives you a different perspective. There's a reason why it does that. So the angles of which this is occurring is different. I'm going to explain that next. So here's a regular EKG. You see the upward going lead 1, upward 2. We're getting somewhat isoelectric because you're seeing some negative in lead 3 and AVL. Lead 3 you're seeing some negative and positive, but mostly positive, right? Because it's mostly inferior. AVR is negative because we're looking at a perspective from the right arm. AVL is mostly positive because our right arm is now being included as a negative, right? So the right arm and the left leg are both being used as negatives, so we're seeing that mostly positive there. And then, right, and nobody says, oh, well, AVL is just the opposite of lead 1. It's like, or sorry, lead 3, it's not. And it's not a mirror image of lead 3 either. It's slightly different because of the fact that you're using two different negatives. And then AVF is positive here because that's where the mass is. The mass is mainly inferior in the heart. And then you have the progressions of the V leads, of your precordial leads, where because you're on the right side of the chest, it's mainly negative, and you're up above the ventricle, so most of this is moving away from you, right? When you're over on V2, again, most of this is moving away from you. There shouldn't be much of a difference, except you're moving closer towards the left side of the heart. So as you begin that movement towards the left side of the heart, you're going to appreciate some more R wave. And then as you continue moving closer and closer to the left side of the heart and getting to the other side of it, you're going to see the R wave progress. That's why the R wave progresses. The other thing worth mentioning is that reading EKGs is difficult because it's absolutely abstract. You're given 12 leads to look at, and those 12 leads that you're given to look at are all in different rotational orientations. But the printout is one printout where you're just seeing all of the activity either up and down, right? And so I'll take you through what you're really being asked to do when you're reading an EKG. And it's to take each one of these leads, in your mind, you're rotating them all around to truly understand what's happening with the movements of that heart. And the reason it's so abstract is that it's given to you in an anti-intuitive way.
Because it goes like this, and then it goes like this.
Right. Does all these different things, right? So these are different examples of flipping leads. So if you flip, so this is where I told you, if you really want to know how to use an instrument, play it badly, and then learn how to play it right. So here, purposely, if you switch the right arm lead and the left arm, the right arm electrode and left arm electrode, right? Now, the computer doesn't know any different. So lead 1 is using this side as a negative, this side is a positive, only you've switched the leads, right? So now you've reversed them. So lead 1 now is the reversal of itself. And so because of that, you have a complete negative deflection here, right? But not only have you reversed that, but now if you put the left leg on the left arm on the right side, that left arm and the left leg normally is lead 3, right? But here, you don't have that anymore. So what's happened is left arm with left leg in these odd positions is now going to be read as lead 2, only that's really lead 3.
So you don't get the isometric.
So what happens is now when it goes right, so now we're flipping all of these around, right? So lead 1 is completely reversed, and now the left arm being over here is going to be read LA to LL in reality, but it's going to be read as lead 2.
Yeah.
And it goes so on and so forth. So I won't do this for every single one of them, but if we look at this next one where you have right arm and left leg, so you mess these up, you're going to have, immediately you know that your lead 2 is going to be inverted because you've just inverted lead 2, right? And so there you can see lead 2 is inverted on this EKG. And now left leg and left arm is really the inversion of what lead 1 should have been.
Got it.
So those begin to flip. So this is why I said, like, don't worry, like, if you're looking at this and you're like, oh, this doesn't make sense to me right away. Like, it takes a while to practice this and keep going through this to recognize these patterns. But they're important patterns to recognize, and do this on purpose so that you can see this on a patient to see what the differences are. It'll help you understand this better. And then right arm and right leg, if you, again, remember the right leg isn't measuring anything. So now if you put the right leg up on the arm and your right leg is down here low, both the right leg and the left leg have the same exact perspective. So there is no electrical difference between them. They're both beneath the heart looking at the same exact event. And so there's no electrical difference between them, therefore it's a flat line in lead 2. So that's how we know when those two have been reversed. If you do right arm, right leg, left arm, left leg, it's the same thing with the right arm, because now you're putting the left arm and left leg and right leg up here, and there's no difference that they're seeing, so that flat lines in lead 1, because there's no electrical difference. So here's a chart that tells you what happens, right? So right arm, left arm reversal, you get an inverted in 1, 2 now becomes 3, 3 now becomes 2, AVR becomes AVL, AVL becomes AVR, and AVF is unchanged because AVF is just both arms are negative and the left leg's positive. So that's where you remain unchanged. Right arm, left leg, this is the pattern, so on and so forth. So, when you're going through emergency training, generally this is a part of your education, is like how to interpret the misapplied EKG. It's crazy that that's how it's done, that we have to learn these patterns. It's ridiculous. But
you can throw the flag on that bogus EKGs right away.
But you can notice in those situations here why, in Africa, that physician was extremely astute to sit there and go, no, this isn't right. There's something completely wrong here with this whole pattern. We need to repeat that and save those resources. Right? Like, so what a necessary skill it is to have that, and important to understand those issues and those limitations.
You find in like those third world countries or people who studied abroad that they're far better clinicians than diagnosticians because they don't have access to diagnostics. So they're talking to their patients, they're looking at their patients, they're feeling their patients, and they're not just looking at pieces of paper and numbers and stuff. So that's why I feel like those ones tend to be a little more astute in like actually clinical practice, because they don't have access to diagnostics,
Right.
They're just like, just doesn't look right.
So and then there's a mnemonic for this called reverse, for common lead reversals. So R is R wave is positive in AVR. This is for RALA lead misplacement. So the R is positive in AVR. There's extreme axis deviation for that. In RLLA, there's very low voltage in isolated limb leads. And you can go through this. This is not a mnemonic that I memorized at all, because I just learned how to read them, and so I don't need the mnemonic. I can see the pattern and go, okay, this is what's wrong. So let's talk about this, right? So again, here's how lead 1 is displayed at the top, right? But really how it should be displayed is how I have it next to it, right? That makes sense. It's mainly a left-sided depolarization, so the electrical activity pulls to that side. That's the orientation of the actual electrical signal. It moves in that direction. Lead 2, displayed like that, but that's the direction it pulls in. Makes sense, because it's pulling down towards where that actual electrical activity is occurring, right? EKGs are really not difficult. What's difficult is that we display them in a way that makes you have to go abstract AF to figure out how to interpret that. Lead 3 is in that direction. So you begin to understand why it begins to become isoelectric, because you're on the same side of the heart, right? So that's the angle that you're at there. In AVF, you're the exact opposite with where you're going. So it's, if you flip it, you see that the electrical activity is moving towards the inferior portion of the heart. That's why it's positively deflected on the lead. But again, everything's moving in that direction. So you notice, like all of these negatives, so to speak, they're really not negatives, they're positive, but where these are all pointing to is the left side of the heart, right? Correct? All right. And left inferior portion of the heart in particular. And so then you get to AVR and you realize, okay, well the two negatives are here, so this is really the inverse of them, because it's positive is up in this direction. But where's the electrical activity pointed? It's where it's always pointed, toward the left. So it's given to you like this, it's at an angle like this, and then it's inverted because of the positive being here and the negative there. So once you do that, this shows you what's happening in reality is that your electrical activity is still occurring in that direction. Nothing's changed about your heart. Your heart hasn't rotated. The electrical signal from the heart is the same electrical signal. It's just that you're looking at it from these different perspectives so that you get to understand that AVR is an inverted, rotated perspective. That's why it should be negative. And you see it here, moving towards the negative. Does that make sense? That one's a little harder.
Can I see this?
So, any questions about that? All right. AVL. Again, our positive is up here. The two negatives are down here. You're at this angle. And in general, because of the contribution of the right hand and things moving in this direction, or the right side moving in this direction, it's going to be a mainly positive deflection. And so that's what we're seeing. So that's just the limb leads. Then you have your precordial leads. Now the precordial leads are often put at incorrect positions. And just before we do that, the electrical axis of each of those leads gives us a different angle. And so lead 1, lead 2, lead 3 have these angles of 0 degrees, 60, 120. AVF is at 90 degrees, AVL is at minus 30, and AVR is minus 150. Even if you know just basic geometry, you'd know that the reciprocal angle of positive 60 is not minus 150. I'm just driving this home that AVR is not the opposite of 2. I've heard it too many times, and it's my little quirk of like, I don't want to hear it again. So this is my little contribution to the universe of not hearing stupid shit again. So V1 and V2 are supposed to be in the fourth intercostal space. That's the intercostal space that's just above your nipples. Not that intercostal space that's just below your clavicle. Nipples, I'm not pointing at my nipples, just for anybody who's on the phone. But anyway, clavicle, right? Two basic things that everybody should know the difference between. Because if your hand brushes somebody's clavicle, you don't get slapped. That's all I'm going to say about that. So, people should know the difference between those parts of the anatomy. And so, what happens? What happens when you put the precordial leads up too high? What happens is that you diminish the amplitude of what you're measuring. So you're dampening the amplitude of what's being measured, which means that you're going to underdiagnose ST elevations by doing that. So these are important diagnostic aspects of like applying this correctly. play the instrument well enough for those of us that need to understand what fucking tune is being played to recognize it and act upon it. And if I can't hear what note's being played, I don't know, right, what to do, and it delays care. And so V1, V2, they are parasternal electrodes. That just means they go on one side of the sternum, the other side of the sternum. Not on the sternum, just to the side. They don't have to be out here. They're there. They're right there on the parasternal, fourth intercostal space, just above the nipple line. And then V3 we'll come back to. V4 is placed along the mid-clavicular line. In almost every human that you can conceive of, the mid-clavicular line lies medial to the nipple. So, it comes down, and you should be on the medial side of the nipple, but beneath it, on the in the fifth intercostal space. Then, the fifth V5 is placed on the anterior axillary line, which is on the lateral aspect of the nipple. I never thought I'd have to teach that aspect of it, but it's know where your clavicles are, know where your nipples are, and you can do an EKG perfectly on everybody. Oh, no shoulders and hips. That's it. That's all. Those 4 pieces of anatomy you need to know. And then V6 is mid-axillary line along V5, right? Along the fifth intercostal space. So let's go back to V3. Where does V3 go?
Between 2 and 3. Between
Right.
2 and 4.
It's a guess. It goes in the guess position somewhere between 2 and 4. 4 is on the medial aspect of the nipple, just below on the fifth intercostal space. 4th, right? There's not a lot of space to screw that up, but it just goes about halfway, right? There is no anatomical direction specifically for V3 where it's on the third part of the clavicle. No, it's just there, right? So guess which lead we don't pay that as much attention to? V3, right? There's with few exceptions, V3 is used. Its R wave, S wave component is an important part of actually diagnosing left ventricular hypertrophy because it's right over that junction. So that's why it's used that way. Anyway, so that's how this is done. Now what happens is most people go down, they fill the sternal notch, and then they put the leads just south of the sternal notch. And that's just, we now understand that's not right. So, again, here's another study. Accuracy in precordial lead placement improving through a peer-led educational intervention. They took 100 randomly selected staff members, placed sticker dots on a mannequin, and asked them to place sticker dots on a mannequin, and they recorded this. The most common errors were placing V1, V2 too superiorly, and they put V5 and V6 leads too medially. They gave an educational session to them, and then they came back to them 6 months later and said, how good was this session? And they found that now 60 subjects correctly placed the leads and compared to the pre-intervention, which was only 10. Right, so 10% placed the leads correctly the first time they did this, and now at least 60% did after getting an educational session.
Did it note on the first part of the study if they're using their fingers to determine the intercostal space? Or are they just guessing? Are they just...
I think they're just
They're just
throwing it.
They're just guessing. And you know that, if 90% of them are doing it wrong, they're just guessing when they did that, right? The educational portions there, so, technically, if there's, 5 of us in the room right now, 6 of us in the room right now, that means 2 of us aren't going to do this right 6 months from now. But you're all smarter than that, so I know that we would have a better outcome with this. But this is the issue. It has to be, and the reason why it falls off is that if you're not practicing it, you won't remember it. So, okay, so kind of the Bible in cardiology is Braunwald's heart disease. This is one of the big texts that you read to understand how to speak to a cardiologist. I've always liked this book, so it's very thorough and written well. The chapter on electrocardiography is actually chapter 12, and we can go through kind of different ways of making other diagnoses besides STEMIs, right? So besides STEMIs, there's other patterns to see, right? So hypocalcemia and hypercalcemia are noted very differently on an EKG and can be diagnosed on that. And hypocalcemia, the main effect that occurs is that you're getting a slow influx of repolarization. And that's just understanding how the cardiomyocyte depolarizes and how the different channels open to sodium, potassium, and calcium. And that during repolarization, it's mainly calcium coming back into the cell that affects this, and it's the duration of time that takes that to happen. So if your calcium levels are low, it takes you longer to repolarize. You have a prolonged QT interval. And so here's normal, right? So your normal QT intervals are about 0.36 seconds. The normal QTC is about 0.41 seconds. The QTC is calculated in a number of different ways. There are a whole bunch of different mathematical formulas for how QTC is done. Almost each manufacturer has a slightly different way of doing this. So GE may use a different formula than Philips does, than Zoll does, and so on and so forth. And different generations of their EKG software differs too, and how QT intervals and QTC are done. So that's why it's important to know how to look at it yourself. And there's the basic rule of thumb of, is the QT interval less than half the RR interval? That has its pros and cons of applying that rule, but in general, that's a good rule of thumb. So many of us apply that as our way of correcting for rate. So QTC is a rate-corrected QT interval. If the QT interval is quite long, this is what you'll see in hypocalcemia. If you instead have hypercalcemia, you have a very quick repolarization, and so your QT intervals decrease, right? And so now it's 0.26 instead of 0.36. So a prolonged QT interval is 0.48 or greater, QTCs at 0.52 or greater. And then in hypercalcemia, you're looking at QT intervals that are short of 0.26 and QTCs that are short of 0.36.
Is that something you would do normally, but just by reading the EKG,
Yeah.
calcium is high?
Yeah. So there's a little bit of clinical context that needs to be applied. Not a little. I mean, there has to be a clinical context to it, right? Patients showing up complaining of palpitations, they've got a fast heart rate. I'm looking at this, and the QT intervals are very short, and they have other signs of, other risks for hypercalcemia. Maybe they've got multiple myeloma, or I can go on of various, they're taking exogenous amounts of calcium and so on and so forth. Then I can go like, okay, yeah, this is hypercalcemia without having to get the blood work back. Like, I know what's happening there.
That's cool.
Patients that are showing up with Shostak signs and delayed reflexes and other things like that, then I know and carpal pedal spasms.
That's your exam.
Right, and they've got a prolonged QT on EKG. Okay, right, and we get those quickly in triage with the way that we triage patients. So if that comes back to me, like, well before the lab comes back, like, I know, like, oh, that person needs calcium. Okay, let's do that, right?
The antipsychotics and stuff.
Right. Then with the antipsychotics, QT interval gets prolonged as well,
Right.
and so this is what we're following. So you're going to start off with sub-normal, and then you're looking to see, do they become this with administration of antipsychotics, or if they already have this, you don't give them an antipsychotic because it'll further delay the QT interval. And if you do that, you're more likely to send the patient into VFib.
But is it also a calcium component, or is that just because of?
I'll have to look at it specifically. So when you get into QT prolongation arrhythmias, the majority of those are either due to sodium or potassium channels. So and that's how they get subtyped. They get subtyped in what type of potassium channel and which of the different types of potassium channels that are in the heart. There's also different subtypes that give you different ones. So there's a case I had, and I can show you later, of a patient who she had an inherited potassium channel problem. And what happened was, if she was in the house and you slammed the door, the loud noise would cause her to pass out. Yeah. And so the family, and even the neighbors that lived around them in the apartment complex, all like literally kind of walked on eggshells around her. They had, like, everybody knew, like, don't yell at mom, and don't slam the door when you come in and out. And they would ask the neighbors, please don't slam your doors, because it makes my wife pass out. And she was seen a couple times at Tri-City, and then she came over to us, and she had a QT interval of like 600 and something. Maybe it was like close to 700. And which is a severe QT prolongation. And it turns out that patients with that type of inherited disorder are sensitive to sound that leads to syncopal episodes. It's a phenomena within them.
So what happens to those goats?
So the different
in the middle of the goats.
Yeah.
The season goats.
Yeah.
Wow, I never knew that.
Well, I don't know that that's the I'm not an expert in husbandry. But my wife will corroborate that. Anyway. Kidding. Okay. Was it that one? No, it wasn't that one either. What was that one? That's right. So,
I couldn't print out Cowway. I tried to print out all the other
that's right. It was
ones.
this
Cowway
one.
wouldn't let me.
Got it. So anyway, in either case, these are kind of the diagnostic aspects of the EKG for diagnosing hypercalcemia. And then in pericardial effusions, we see this. Now, this is an extreme example of it, because usually it's more subtle, but where you're going to see a small complex, a large complex, a small complex, a large complex. This is called electrical alternans. It's not because the electrical signals are going opposite of each other. They're not alternating opposite. What they're doing is the amplitudes are alternating. So one R wave is short, the next R wave is tall, short, tall, short, tall. What's happening is the heart is floating in fluid, and it's moving towards you and away from you.
The fluid wave.
And towards you and away from you. So it's getting, these are surface electrodes, so you're moving closer to an electrode, higher amplitude, further away from the electrode, lower amplitude. So somebody who has COPD has an inflated chest, right? They're barrel-chested. So their heart is further from the chest surface.
Lower amplitude.
So they have lower amplitudes. So it's why we can look at, without seeing a patient, I can look at that and say, oh, this person probably has COPD because they have low voltage all the way throughout.
They're really big.
Right, or they're really big. Or I see somebody, you bring me somebody with really huge R waves, and I'm looking at, a 10-year-old EKG. I'm like, oh, okay, so skinny 10-year-old. That's got, heart right there. So big amplitudes. These differences of alternating back and forth, that says that electrical alternans can often be more subtle. So the R wave is like this, the next R wave is like that, then it's like that, and like that. So some of these cases, the only way to pick up on them is if you have an unusual amount of time on your hands and you break out some calipers and you're measuring the difference of the calipers. The more easy way to do that in those cases is just take an ultrasound and go look at the heart and go like, oh yeah, this is pericardial effusion. All right. But that takes effort, right? We got to find the ultrasound, get it over to the room, stuff like that. So it's not always easy. But this is a way, like if somebody shows me this EKG, like right off the bat, I'm like, oh, that's a softball for pericardial effusion. Let's see.
I know, you want to get a look.
What would you do mine if you do?
I don't know why it just froze on me.
I think somebody called in or something.
No, they're,
Oh, they left.
Let's see. I'll just switch screens for a second to see if that helps.
Page. iCloud is not responding.
All right, something came back. So let's see if I do that. So in the meantime, I'll just show you this EKG here. So here's the EKG of what was coming from the field, and so this guy is being read as a heart rate of 81. Now, one of the things just to understand about EKGs in general is that these are 10-second snapshots, all right? So this is, the whole thing is only 10 seconds. So if you go down and you just multiply anything by 6, you're going to get what your rate is per minute. So, and what it does is, what these EKGs really are 2.5 second snapshots of intervals. So 2.5 seconds of lead 1, 2.5 seconds of these 3 leads. So there are 3 leads, generally at 2.5 seconds next to each other. So 2.5 seconds, 2.5 seconds, that's 5 seconds, 7.5 seconds, 10 seconds. And if you look here, there's a QRS there. Maybe another one-ish there. There, maybe. There, and there. So that's 30, right? 6 times 5 is 30, so that's what the rate is. So the computer-aided interpretation is faulty in a number of different ways. So much so that I never use it, like never. So I almost always go to every EKG and go like that, and just mark that I'm not using the computer-aided interpretation because they're faulty in so many significant ways. It's amazing when you meet with the people that invent these and are working on these, and you talk to them about their computer-aided algorithms, how much time and money they spent with mathematicians and with electrophysiologists and everybody else to put together a really shitty instrument. And they get offended if you're like, oh, it really sucks. The people that work with it and that do the research with it understand how bad it sucks, and so they're just like, oh, this could be done way better. And it really can. There's like a whole bunch of things to do it better with. But so it reads it as a STEMI, and you can see here the baseline's wandering, and the ST segment is elevated in 3. It's elevated in 2. It's hard to tell what the hell's happening in IVF with that. And it's wide complex, and the overarching theme here is that this looks sinusoidal. So bradycardia with a sinusoidal pattern is hyperkalemia. And so this was one where they wanted to know, should we give aspirin and nitro? And I was like, you should give calcium and bicarb and then bring us a live patient. That would be good. And so they did that and brought that patient in, and they said en route that it went from heart rates of 30s to heart rates of 70s. Wow. And so now with heart rates of 70s, the patient arrived looking a little bit better, and then in front of us went right back into the 30s. And we got an ISTAT, and the ISTAT had like a K of 6.2, and the creatinine was double from baseline. But that's after already getting 1 amp of bicarb. Wow. And then now we've given another amp of bicarb, another calcium, heart rate comes up to 60s, and we get a nice narrow complex EKG, and then it drops down again to the 30s. And this is when it got interesting because we did an ABG and now showed that we brought the potassium down to 5.3. So now the bradycardia is no longer due to that. We're shifting. This is all going to be temporary, right? So the fact that it's going back and forth isn't a surprise. The surprise is now we've pushed it down and we're still bradycardic. And so something has diseased the actual electrical activity, and now he's stuck in a severe bradycardia. So that patient now needs a pacemaker.
Was he an acute renal or a chronic renal?
Acute. So normal creatinines are 1.2, and on this day they were 2.7. So there was definitely an acute kidney injury, acute hyperkalemia, but also a severe bradycardia that was going along with this, and it wasn't due to any obvious medication issue. Patients on calcium channel blockers, but wasn't known to be taking too many of them.
It's the channel that's broken.
Right. And calcium channel blockers are generally cleared by your liver, not by your kidneys, so that's not a typical cause of that. So at least diltiazem in particular is cleared by the liver. So that wasn't going to be an explanation. The patient was only on 25 metoprolol twice a day, so that's not an explanation really for it's not a beta blocker toxicity. So we placed a pacemaker in that person, and that helped keep him around.
Do you think he had bradycardia for so long that it was a low perfusion situation for the kidneys, and that's why it was an acute injury?
It's a good question. I don't know the answer to. Hopefully they'll.
Did he come in with a chief complaint of syncope?
He near syncope actually.
Dizzy.
Sorry, I'll relog into this to get the rest of this going. We're actually almost towards the end here.
Probably dizziness, weakness, near syncope. You know, the usual. Was he only like in his 60s?
I just want to say he was in his 70s.
Oh.
72 to be exact. But it was a fascinating case to play with because the repeat EKGs, again, didn't show any ST elevations, but there was an elevated trope, so there had been chest pressure and discomfort for several days. There was an end STEMI to some of this, so probably the ischemic injury led to electrical problem, which led to hyperperfusion, which then led to all of that.
Right. And then poor renal clearance, and blah, 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 blah.
Right. Plus also taking potassium chloride supplements, while also taking Lasix, and on anticoagulation therapy, so placing the line was a lot of fun. Even when they shaved him for the EKG, there was a lot of bleeding. So that had created an interesting problem.
He would have died in Africa.
Well, without a pacemaker, yes. I don't know what that extra sound is.
Dr. Dunphy is calling in.
Quit calling Dunphy.
Dunphy, just
He's off.
Stay or go.
text me, dude. Then I can see, oh.
You did.
Aha, forgot you, Todd. All right, great. Thanks. Press play here and then I'll get back to it. Sorry about that. There's always some sort of technical hurdle. Come on, go back.
Same for you.
Okay. So pericardial effusion. Now the next one is hypothermia. In hypothermia, what we're seeing is a wave following the QRS here. These are called Osborne waves. This is what's seen in severe hypothermia. So if I have an EKG that's given to me that shows me this slurring and this extra wave following the QRS complex, or the terminal portion of the R wave in V5 and V6, that is an Osborne wave. And so by looking at the EKG, so if I get this as a pre-hospital EKG, and they're like, this is what we're showing you, right? How often do they check temperatures before giving us a patient, right? And if they do, like if they did, it wouldn't register, right? It'd be too low on whatever their automatic reading is. And so we would just get like, hey, temperature's too low. Well, send us the EKG and see this. And we're like, okay, this is a severe hypothermia. Now, Now, Osborne waves are not seen in every case of severe hypothermia, so it's not a sensitive finding. When it's present, it can specifically denote that the patient has that.
How hypothermic do you have to be to present?
This is usually somebody who's below 92 degrees, getting to 88. You see it, the frequency that you see it is higher in those that are 88 degrees and below. Those that are in the 90 and the low 90s will also have Osborne waves. So, hyperkalemia, right? So in hyperkalemia, you see these peaked T waves. These peaked T waves are symmetrical, right? So they're tented like this. So tented T waves are a sign of hyperkalemia. Widened complex is also a sign of that with bradycardia. So somebody with bradycardia, wide complex, peaked T waves, those are concerning. Now the T wave peaking begins to diminish with the severity of the hyperkalemia, and they begin to kind of flatten out, and that's when things start looking sinusoidal. You can't kind of tell you can't kind of tell where the T wave is and where QRS complex is, because you're just seeing one wave next to another. And so we've had several of these from the waiting room that we've diagnosed, where like you're just sitting there, EKG comes in front of you, you're like, oh, those T waves peak, get an iStat on them, and the case 7 point something. You're like, that's a good person not to leave in the waiting room, right? So hypokalemia, you're going to, instead of having a fast influx of potassium through a portion of this, you're going to also have additional waves of potassium coming back in. So you have an additional wave that's present. You have what are called U waves. So you have your P, Q, R, S, T, and then U waves that are present, and they can be subtle. So here's your T wave, and there's a little U wave. All right, and you can see QT prolongation in these patients as well. Brugada syndrome. This is a syndrome of sudden cardiac death. Right, it presents with a pattern of right bundle branch block, with the terminal portion of that R wave giving a deep inverted T wave that occurs. This is because of sodium channels in general that are causing this. This is type 1 is highlighted here because there are three different types that we can see on an EKG appearance for Brugada syndrome. Type 1 is the only one that's diagnostic. The other two are not diagnostic. So if you miss those, okay, that's kind of standard. For type 1s, we're not supposed to miss those. Those are the ones that we're supposed to be diagnostic of and know, like, okay, there's a deep asymmetric inverted T wave following a right bundle branch block pattern. That's a patient with Brugada syndrome. They need a pacemaker and defibrillator, because otherwise they're going to have sudden cardiac death. So there's a website that's maintained by Harvard. That's a really great learning website, and I'll give you that website later. But what they have is a self-learning tool, so you can go through hundreds of EKGs, and they'll give you a scenario. This is an 18-year-old pre-op ECG for knee surgery. What does this EKG show? And every EKG that I interpret, I first note what the rate is, what the rhythm is, what the axis is, and if there's any ST elevations that are present. And I sign every EKG with that interpretation every single time. And the reason I do that exercise is that it forces me to commit to an interpretation, and I'm not going to miss a STEMI that's in the waiting room or anywhere around me. And it makes me interpret things, so just for a moment, and I put that down. Now, I know that EKG is going to go to other providers sometimes, so I purposely only mention, if it's sinus rhythm, what the axis is and that the ST segments are. So I'm not boxing anybody else in on their interpretation of the EKG. I'm giving a very basic, minimal interpretation that's safe enough to disposition that EKG and that person without boxing my colleague into a different interpretation later. But
do you have limb leads mixed up?
So why do you think the Lynn leads are mixed up?
Because I thought it was supposed to be positive, positive, and then like neutral in 3.
One is isoelectric.
One is isoelectric, which should be in 3, and you should have the other deflection on 1.
Right. So the answer is Lynn lead reversal.
Okay, sorry, I was like, wait, what's wrong?
Right. So here you've got a limb lead reversal. The left and right arm are reversed, right? And so you see an inverted P wave in one, and the QRS complex in lead 1 is abnormal as well, and was inverted when it shouldn't be.
Okay, I was like,
Now, the way we get a sinus rhythm is by looking at P wave, upright P wave segments in leads 2, 3, and AVF. We don't see it here because this is the bad EKG, but this is basic and fundamental, but it has to be repeated, because in my practice I've been fooled before in somebody who comes in with a flutter, or a slow A flutter, slow A fib, where there isn't a P, you're not seeing P waves in 2, 3, and AVF that are upright. And that basic issue of being able to recognize somebody who's an A flutter and that's like they're having palpitations, they're not feeling right, you haven't done an echo yet or looked at them. And a lot of these patients, you're not going to do echoes. You can't echo everybody. We just don't have time to do it. But you can suddenly realize, like, okay, no, this person's A flutter. They need to either get cardioverted or anticoagulated and cardioverted later. But nonetheless, that's kind of what we have there. So you need to have that to know, is it sinus rhythm or not? And then the axis has to be determined. The reason what the two major divisions between just, if all you walk away from is basic aspects of the axis, left axis deviation, you should be thinking ischemic injury to the heart. Just that simple. And right axis deviation, you should be thinking that there's some form of right ventricular conduction problem. There could be pulmonary embolism. Those two simple things for the emergent aspect of how we triage an EKG, really simple. So if it's right axis deviation, in your mind, it should go off like this patient might have PE. And if it's a left axis deviation, in your mind should be like, this may be ischemic injury to the heart. You still have a history to get, you still have a physical to do, you still have laboratory studies, but these are the early warning signs of, like, you know, looking back over the course of your career, were there times that you could have been faster in recognizing a disease? Well, this is the way of using the EKG to do that. And the next example is a 21-year-old female with history of seizure disorder. She's on no medications. Her electrolytes are normal. The ECG is most consistent with which of the following? Parkinson White, long QT syndrome, hypokalemia, tricyclic overdose, or hypothyroidism.
Well, there is a prolonged QT that how do you know if it's
right?
something else?
So here, right here you see the QT interval, and that QT interval is longer, is more than half of the interval between there and there.
Right.
So again, it's just a rule of thumb. It's not a perfect rule, but this prolonged QT interval needs to be recognized so that way this patient can get adequately treated. And this patient's got long QT syndrome, right? It says here, EKG demonstrates sinus rhythm with a very prolonged QT interval of 0.6 seconds. There's broad T waves with notching or possible U waves in the precordial leads, characteristics identifies with long QT syndrome and increased risk, so on and so forth. I won't go into what everything that's written here, but you can see what a valuable kind of self-learning tool that this is. So even if you're not quite getting them right at first, you'll just keep practicing, getting better and better. It's just like I don't expect my daughter to walk out like Miles Davis with her trumpet. But we're so hard on each other and especially on ourselves when we're looking at how do we look at EKGs. We see them all the time. We think we should be experts in reading them all the time. But the truth and reality is that unless we're really practicing and being introspective about how we're doing this, we're never going to be really good at it because we're just going to accept the way we do it. And again, the data shows that as in general, we don't do them well. So here's another good EKG that shows, this was that patient I referred to earlier that was passing out with loud sounds. And you can see there's the Q, there's the end of the T wave.
Wow.
the key thing about this, and the reason I use this as an example, is that checking out the QT interval in every lead is difficult, right? It's hard to find the QT interval there. So what you're better off doing is trying to find the best example of the QT interval, and that's the lead that you then study to say, I'm going to compare this one to, right? So once I go, I'm like, there, I'm like, yeah, I'm just about on the next one. That's way more than half that interval. That's the way to do that. Is find the more extreme example within the leads. And then again, this goes back to the issue of this is why it's important to have multiple leads, why having 12 leads is diagnostic, and why having 5 leads and 3 leads isn't. Just as simple as that. Here's 36-year-old male, hypertension, hypercholesterolemia, presents an ER with 3 hours of chest pain with this ECG. How would you manage this patient? Thrombolytic therapy, urgent cardiac angiography, conservative management with nonsteroidal analgesias, workup for pulmonary embolism, or urgent transesophageal echocardiography. So the first thing is the rate. So if we go down the rate, each one of these lines corresponds to a slightly different rate. So the next box is 300 beats per minute, 150 beats per minute, 100 beats per minute, 75, then 60. And it's kind of how that goes in a regular 25 millimeter per second EKG. So we're looking at a rate here, and you could do this an easier way if you want. Just go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. Multiply that by 6, right? So that's 60 plus 24 is 84. So that's more or less a rate of about 84. You'll see that here again. If you find one that's kind of on a line, 300, 150, 100, between 100 and 75. So 84 makes sense. So the rate's 84. Is it a sinus rhythm? Well, there's an upright P wave there. It's kind of hard to see. Maybe an upright P wave there. Maybe an upright there. So maybe not. Not quite certain. Is the axis normal? This is a matter of, is it positive in one or an AVL, and is it positive in AVF? If it's positive within those, that'll be normal axis. And then are there ST segment elevations? And so we'll start looking, and it's like, well, there's the TP segment here. Here's the ST, that's elevated. Hard to tell. Elevated. 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 Elevated.
Are you pericarditis or?
So if you have diffuse ST elevations and PR depressions, because you're seeing the PR interval slightly depressed there, and there, those are signs of pericarditis. So the treatment here is conservative management with nonsteroidal analgesia. One of the things to note here is I'm purposely choosing all the difficult ratings.
Why did you say nonsteroidal? If it's an inflammatory disease.
Because pericarditis is treated with nonsteroidals. Actually, the best treatment is to give both nonsteroidals and colchicine.
That's what we did the other day.
Because pericarditis is a condition that's often recurrent, and it's less recurrent if you give colchicine.
Dr. Chen said if you have global ST elevation, the reciprocals aren't really a reciprocal.
Right.
And he was young. My guy there was 25. We gave 600 of ibuprofen and colchicine 300.
No, but less than that, but yeah.
It was just colchicine, and we're like, okay, well, he's got gout too. He's like, no, he's probably pericarditis.
But that's an inflammatory disorder, it's gout, so.
Yeah, with myocarditis as well. So
right.
He got admitted. He was 25. He looked great.
Myopericarditis is something to look for. You look for it to see if they have an effusion too. So this would be one where if you're breaking out so this is that example. So if you were looking at this, there's some notching here that suggests like a benign early repolarization that's occurring, but you only get benign early repolarization leads V3, V4, V5, V6. If you're seeing a notching, this is called J-point elevation. If you have J-point elevation in your inferior leads, that's pericarditis. It's not early.
Delta wave or something like that.
It's a slurred wave, but it's not. It's J-point elevation is what it is. And so So yeah, so, and then those patients get admitted to get echoed. If you echo them, they don't have any ventricular abnormalities and there's no large pericardial effusion, then they can just be safely discharged even if their troponin is elevated. There's not much to it.
My last
Except
patient
treatment.
was a drug abuser in his 30s and had that global elevation,
Yeah.
and we found it in triage.
Yep. And then this is just an example of just, I sign it and I put the rate, if it's sinus for them, if the axis is normal and whether there's not any ST elevations. Just, it's helpful to do, particularly when you're busy.
Very methodical.
Here's a patient that I saw. So this was, oh, come on. Really?
Well,
How did it do that?
Done for you. Ghost.
All right. No, not, yeah, right. So what was interesting about this patient was that you see how the P wave is so close to the R wave? Like the PR interval is extremely short there. And so I saw this patient and I was like, oh, like I saw the EKG, I'm like, oh, I'm going to grab this one right now. Right, the rate's 65, sinus are the normal axis, there's no ST elevations. There's nothing generally that when you look at that, you go like, oh, this is something I need to see right away. But that short PR interval is a sign of what's called a pre-excitation syndrome. And so those are patients that can just suddenly kick in. And so I walked in to talk to her, and I was like, hey, have you been having palpitations? She's like, oh, I've been having palpitations left and right. I don't know what's going on. But they're coming and going. And as we were talking, she went into it.
You got her
And so
excited.
she was a rate of 65, right? And now she's a rate of 150. Right? So
her PR
I'm
interval
stimulating
is
when I
not
talk to
different
people, but not that
there.
stimulating.
Her PR interval is different there than it was on the initial.
Well, now she's in a reentrant tachycardia. So we're getting a bunch of extra waves. So that's what a pre-excitation syndrome looks like. So it comes in looking like that, and then they do this.
Get an ablation later.
Yep.
And it wasn't hypercalcemia because the early PR interval, the short PR interval is not coupled with a prolonged QT interval.
Correct. Yeah, she didn't have any electrolyte abnormalities. This is
What was
all
her chief complaint?
palpitations.
Oh, it was?
Yeah.
I thought that was coincidental when you
No.
came in to say, oh, you didn't know her.
No.
You came in and
All I had was
asked
this.
her.
All I had was this EKG. So I was like, I rushed into the room and I was like, are you having palpitations? And she was like, yes, I am. And then as we were talking about it, then she went into that.
I love it.
So, all right. So this next one, this is elderly female with admitted with obtundation. What electrolyte abnormality is strongly suggested?
Hyperpotassium, hyperkalemia.
Right. You see tented T waves here, and that's the first sign of that is you see tenting of the T wave, and then the QRS starts to widen, and then things start to go from there, and the bradycardia continues. But bradycardia with a tented P wave, that's what you get.
How do you explain the low amplitude of the P wave?
She's old.
Was she obese or COPD?
This doesn't look like COPD to me in particular, but she may be a large person because we are seeing low amplitudes in all the limb leads, so it's suggestive of that. All right, so there's hyperkalemia, and then this next one was a good case of hyperkalemia as well. See those nice peaked P waves there? All right, so this was a trauma case. This was a trauma case that went into cardiac arrest, got coded for 15 minutes, got an amp of bicarb, an amp of epi, and some fluids.
Did he get tamponade?
No.
It was a head injury? Did they
Nope.
syncope and fall? And then
They had fallen, there was syncope, they'd fallen, and they broke their femur. And so they came in as a trauma activation, and then
With a low
an EKG
GCS?
was obtained. And, well, confusion. I don't know how low the GCS was, but it eventually became 3 when they went to cardiac arrest.
Sure.
And so this was, and I don't think, I'll have to look, I have got the chart somewhere else. I don't think they RSI'd If they did, that could have further complicated things, depending on what agents they used. But either way, this patient went into cardiac arrest, got CPR for about 10 to 15 minutes, got those medications I mentioned, and then was pronounced. And blood was drawn, and an ISTAT was resulted after declaring the patient, and the case came back as 7 point something. Well, that's not helpful, right? It's helpful if you keep going with CPR and then get your ISTAT result. And this is just something that it's not unique to our hospital. This is a ubiquitous problem across all hospitals, is that during cardiac arrest, the amount of diagnostic information that's obtained is usually done poorly.
Yep.
We usually don't do that. Even in our own patients here and elsewhere, it's rare that somebody draws blood during the cardiac arrest to make an attempt at a diagnostic opportunity.
Well, it's you always are, right?
So, but as a system, our system doesn't do that, right? And many systems don't do that, and so it's a blind spot, and it's something that we all need to be much more vigilant about, because in my estimation, if I take this, and this is an EKG at another hospital, and I'm called in as an expert witness to look at this, my criticism isn't of the attending physician for the error in not seeing that, right? So this is hyperkalemia, right? This patient here, has hyperkalemia, but during the arrest, that's not picked up on because they're focused.
And they're not doing a
Okay.
12 lead, they're doing
So
a...
this was a 12 lead.
Oh, I
This
see
was
what you're saying.
the patient got
In
a
the
12
trauma
lead.
room?
Yeah, in the trauma room, right? My own take on this, and this is a very biased take, is that we have decision support instruments. We build the decision support instruments into our code blue sheets. Our code blue sheet has a directive for the person who's making the recording to interrupt the code to announce the 5 H's and the 5 T's and to ask, have we given early consideration of that? But what happens is everybody grabs a blank piece of paper and wants to write on a blank piece of paper instead of using the code blue sheet. In the trauma situation, because there's a trauma sheet, the trauma sheet doesn't have that decision support. So my criticism as an expert witness in a case like that isn't critiquing the particular provider, it's critiquing the entire system. I would hold all of the providers in the room and say, everybody is at fault for this one. This is not a single provider mistake. This is a systemic mistake, and it's because every person in the room didn't consider those and aren't using the available tools to them to make those considerations. In this case, the available tool is EKG. EKG showed what the etiology was. The best marker of the time capsule of your body for your chemistries is your eye. So when this person went to the morgue and had a forensic exam, they take out the vitreous and they measure the chemistries of the vitreous. And the chemistries of the vitreous had a potassium of 8. So if you off somebody by trying to give them, potassium chloride, this was a thing in the years past when it was also a thing like for euthanasia when people were trying to help somebody move along, all right? Instead of overdosing them on morphine, they would just give them a dose of calcium chloride because it's in and out of the system quickly in terms of serum studies. The forensic pathologist could know if somebody was poisoned by just pulling the vitreous out and going like, oh, this is what the potassium was when they died. So it's your little time capsule, is your vitreous. And so so this patient died from acute renal failure when what they needed was dialysis, and instead got an AMP of bicarb and some stuff. And the bicarb isn't the treatment for hyperkalemia that's life-saving. The life-saving treatment is calcium. Stabilize the myocardium. That's what's necessary.
Traditionally, our minds change tracks. Once you're in a rest sequence, we go to a rest. We forget all that metabolic stuff over here, and we're following our...
And everybody thinks heart attack, right? Like, it's one of the leading causes of death, so it's a reason why we should think heart attack. Like, that's the natural thing to do, but it's not the methodical scientific thing to do in those arrests. The methodical scientific thing to do is to consider those H's, those T's, because they're reversible. Right? Not because that they're most frequent, it's because we could do something about them. right? If I have somebody who has hypertrophic cardiomyopathy, that's not one of the H's. And that's one that I can't do anything about. If I have something that's blocking the left ventricular outflow tract, it doesn't matter how hard I press on the chest, doesn't matter how much medicines I give, blood is not coming out of the heart in hypertrophic cardiomyopathy. That arrests. That's what happens. So that person's going to die. And I'm not fine with it. I'd be better if we had ECMO and we could ECMO them and then figure it out and treat them. But I can put my head on the pillow knowing that there wasn't anything more I could have done medically at that point in time. From a system space, we're still leaving people lying on the floor that don't need to be lying on the floor. And this was one of them. This is where this happened. So this was diagnostic. So I figured, this is one of the main reasons I wanted to teach this particular issue, was so that way we all recognize, like, in the future, if we get a trauma patient that has peak T waves and that looks at shit and they're in cardiac arrest, let's treat what the information is.
You were in the room and you saw this before the patient arrested?
No. So because I'm co-chair of the Code Blue Committee, I review.
I see.
And I've taken on a different thing where I've decided to review every Code Blue from the last year, not from 2019, but 2018, because I've got various different coroner's reports that I can go back and figure out what actually happened. Why did that person actually die? And then we can look back at the data to see what was there to then support that and then learn from it.
Right.
So that's the point of me being critical of this, is to help us learn so that way next year we don't make the same mistake. So here's a patient. This is the patient EKG with an inferior STEMI. They came in shock, and this is the patient that was having, and you could see the reciprocal changes here. So this is a diagnostic EKG for an inferior STEMI. And then with them being in shock, this is indicative of right ventricular infarct. So they're fluid dependent. They need fluid, right? We don't want to give things to take fluid away. So we're giving fluid. We're putting central line in this patient, trying to get them up to the cath lab. And get up to the cath lab, and they put the catheter in to inject the contrast, and they can't see an artery. And then they pull back out, and they push contrast again, and they realize that they're in the dissection flap of an aortic dissection that's dissected through the coronary artery. So this is a patient that came in with a acute STEMI due to right coronary artery dissection from a larger aortic dissection that this patient succumbed to.
Had they done a CTA prior to and know that they had a dissection?
No, they saw the EKG and went to the cath lab, probably.
Right. We did a chest X-ray. We did a chest X-ray on this patient because we'd intubated, put a central line, and done stuff. This was on a weekend night, so it took a little while for cath lab to come in, but not much.
If they're widening, do they?
And the chest X-ray was normal. And so the dissection was anterior. Yeah, it was huge. And it was an anterior-posterior dissection. So on a plain chest X-ray,
it wouldn't have mediastinal widening.
You don't see a widening of the And 12% of patients with dissections have normal chest X-rays. So these are supposed to be diagnosed in the cath lab, and then there's some controversy as to what's the best thing to do. Some suggest that you should just, while you're there, stent the lesion, so get into the true lumen, stent it, so that way they're maintaining coronary artery perfusion, to then get them to the CT scanner, find it, see if there's aortic valve involvement as well, because the cardiothoracic surgeon needs to know if they're doing an aortic graft or if they're doing an aortic graft plus a valve replacement at the same time. Those are important things for them in the pre-surgical decision-making.
So the type 1 or type 2, whether it's dissecting into...
So type A and type B. And type A is easiest to remember because it involves the ascending aorta. That's all you have to remember is A is ascending, and then B is descending. So from the left, below the left subclavian artery. So it's where it's the starting point, not the finishing point. So the starting point is involving the ascending aorta and aortic arch, type A, even if it carries all the way down to the toes. Type B, it starts below the left subclavian and carries down.
We had a guy last
There's no way on the
week
EKG to determine what was happening with regards to that. That's not diagnostic. This is diagnostic of an inferior STEMI, but I'm sorry, you said?
The guy last week that had type 1, he had an arch repair over at Tri-City last year.
Yeah, I took care of that guy.
Oh, yeah. But then
Or is it both?
he had another dissection that went down into the right iliac. but it was non-surgical, and they were suggesting that if it's, you told me, I think, if it's under the ribs, it'll be cardiothoracic, but if it's anywhere below the ribs, it'll be vascular.
Right.
But they ended up not doing it at all, and I wondered if their plan was a stent.
It turned out that that whole dissection was old, even all the way down.
All the way down?
Yeah. We just didn't know that because we didn't have a previous CT down there too. Yeah.
That was very interesting, because I watched the CTA as it was happening, and thought, oh my God.
Yeah.
'Cause I didn't
And that's the thing, once
see
you
the
tear,
growth, it's
once
just
you,
like, whoa.
right?
All the way
It's like a pair
down.
of jeans. It's torn. You might mend it. It's still torn.
Yeah. It was like,
So-
we're in trouble. I came back going, sweating. I thought, this is very bad.
Yes.
All the way down.
Yeah, that patient got us all worked up for a while.
Yeah. Yeah.
So ended up doing okay in the end and getting discharged without any specific intervention except just a consideration of an outpatient procedure. So this is the actual kind of physiology of a myocardial a myocyte depolarization, right? So you depolarize and then you come back during electrical diastole, and then you depolarize again during electrical systole.
Looks like end tidal.
And so, yeah, right.
Oh, it is?
No, it's not end tidal. But this is this is the specific electrical potential in a cardiac myocyte.
Okay.
So red or pink is normal, right? And so what happens in an ischemic injury is that you're losing strength, right? The muscle's dying, so it's not going to be as strong. So the potential decreases. So first of all, you get a lower potential, right? Top to bottom is lower. But what also happens is that your repolarization repolarizes to a less negative level.
So it doesn't have to work.
So the ST segments elevate. The repolarization is less repolarized than normal, so the ST segments elevate. That's what's happening here. So you see how normal would be here, ST segments, this isn't an ST segment, but I'm just giving you an idea that you're getting an increased from the baseline. So lower amplitude because it's weaker, and the repolarization is at a higher level than minus 90. Minus 70 is higher than minus 90. So that's what's happening there. So you've got a PQ, RST, QT interval, and then this ST segment demonstrates what's occurring most sensitively during repolarization, and this is why we see those segments in there. The rest of it, it's hard to see. It's happening here. What happens in an acute MI, because the amplitude decreases, the R waves actually decrease from baseline. But you don't know that because you didn't have a baseline EKG to compare to. And you weren't going to sit there with calipers trying to figure that out. So ST segments are what we're using as our way of recognizing them. I hope you're starting to understand, though, that there is a limitation to that technique, right? All these different waves and all these different parts could be measured to show this. And there's certain ones that are a little more sensitive than others to be able to see that, but none of them are 100%, which is why our diagnostic use of EKG for STEMIs is only 50% positive half the time. And the most important thing that we need on our chest pain patients is both an old EKG, so I'll say two most important things are an old EKG, so we have a comparison, and secondly, as a repeat EKG. We need serial EKGs. We don't do serial EKGs enough, and it's a blind spot for us again. And it's that way in a number of different hospitals. The reason we don't do EKGs enough is because it takes time and effort.
Are you going to get into bundle branches at all?
Not too much, because,
So why?
but a little bit.
Okay.
Into how to diagnose a STEMI with a bundle branch? Yeah.
Well, yeah, because, I mean, how do you differentiate an active STEMI, like an acute STEMI, when someone already has that bundle that throws everything off? Like, the bundle gets misread sometimes as
A STEMI.
a STEMI.
Yeah, because it's a computer-aided
Right.
algorithm by a
Well,
bunch of those mathematicians that
You know what I mean?
had somebody put the instrument on incorrectly, and then it doesn't interpret it correctly, and
Right.
there's so many reasons why that happens.
Okay.
And the first part is the instrument has to be applied correctly first before, right?
Right.
So again, in ST elevation infarct, think of this as a diastolic infarct, and you're seeing obvious diastolic injury, where the ST segments are going to kind of be pulled up, right? So a normal resting cell that's normally polarized, you have a lot of negative potential and then increased sudden positive potential. In an ischemic resting cell, it's only partly depolarized, and therefore it remains at a higher level.
It's diastolic failure because diastole is when the coronary arteries get fed with blood.
Right.
Right?
Right.
Okay.
It's also electrical diastole. And in primary ST elevation, again, you've got a normal depolarized cell, and then ischemic cell has early repolarization, hyperacute T waves, and incompletely depolarized, which is why the ST segments remain elevated. All right. So those are a couple ways of how you approach this. It depends on how much of the wall is involved. If the wall has a thickness to it, so if it's a subendocardial injury, you may only see ST depressions. When you see that it's fully transmural is when you see the ST elevations. So we care about picking up acute MIs here because we still have this tissue to save that we lose when we have when we see some of the ST elevations. That's why these patterns are important to recognize.
At what interval would you recommend serial EKGs?
The American Heart Association recommends intervals 15 minutes. So
if the doc doesn't bring it up, maybe we could suggest it.
Right.
Like
So
nitro.
acute chest pain in the first, right? So that's what's recommended. But think about the person coming to triage. How many of those are we going to realistically repeat within 15 minutes, and then still get the new patient that shows up with chest pain? Like it's not as practical. But patients, in my opinion, patients should not be leaving the ER with chest pain with 2 negative troponins and 1 EKG. They should leave the ER with 2 EKGs and 2 troponins. That should be a minimum. But and I'm not trying to institute policy. I'm just trying to. This is just coming from the idea of where do we have a blind spot? Where are we vulnerable? That's a vulnerability, because the lack of serial EKGs leads to increased risks of misdiagnosis of MI, because the chemical changes over 3 hours may be missed as well, and that's not a sensitive enough instrument to pick that up.
That's a good
So
reason.
serial
Tabs
EKGs.
on, and then you can come back quickly and do it.
Yep, but those tabs fall off too because the tabs are cheap. So
I don't know.
I'm maintaining my disclosure by not. But somebody out there may have figured something out, how to fix that. Anyway,
We'll work on
We still need an order at this point in time. We can't just do it like on standard.
you're
You
right.
suggest it to
You're
the
right.
doctor.
Not yet.
It'd be nice if it was standard, then we just do it like our last set of vital signs.
Well, and it would be nice to have a repeat standardized troponin too, so that way, like, that would just be part of the standard orders. You got a troponin on arrival, and you got a troponin 3 hours later, and you had an EKG done at the same time the next batch troponin was done, and that would make sense.
Now, you can't mix match tropes, though. Like, if you do a lab trope, you can't do an ISAT,
Right.
vice versa.
Right, you're right about that. Yeah, same instrument has to be used. So, and it's also why the same is true for EKG instruments technically, right? So it's why when the pre-hospital EKG is done, we're supposed to do an EKG on arrival, and because we're switching instruments. But so here's also an example of an ST elevation MI. These are different patterns of early ST elevations that you can see, and then evolving down, so the T waves come up, the ST segments come up, and then you can have a flipping as this is going through evolution. So this is ECG with an anterior lateral Q wave infarction, and so the lateral Q wave infarctions you're going to see in V2, V4, V6 Q waves. So there shouldn't be Q waves at all in V4 and V6. So any Q wave is abnormal there. You're allowed to have Q waves in 2, 3, and AVF, but they have to be less than 30% of the QRS complex to be considered normal. If they're more than that, then they're considered abnormal Q waves. And the Q waves really demonstrate true transmural infarct, as opposed to the ST segment involves the myocardium and generally in transmural, but not always, because it can still be a partial submyocardial, just a large area involved. This shows an evolving inferior posterior lateral infarction. So you have slight ST elevations with deep T-wave inversions, right? So that's a finding that's concerning for this, and you're seeing the T-wave inversions, the V4, V5. If this patient's presenting with acute chest pain that's consistent with an acute MI, this is something where we should start getting the cath lab ready and get...
And evolving inferior lateral.
Right. There's also what are called pseudo T-wave normalization. So this is one where the patient's having chest pain here, but their baseline is a T-wave inversion. And T-wave inversion is generally somebody who's already had some prior injury to their heart. They now have chest pain, and they've got upright T-waves. This is their hyperacute T-wave. So this is the pseudo T-wave normalization, which is actually a STEMI. These are tough diagnoses to make.
You would never know that if you just got
if you just get the EKG brought in front of you from triage. It's why, like, when you're doing EKGs, like, you got to tell me if somebody's having chest pain and they don't look good, even if it's a normal EKG. Like, that's what I want to know. Just go. This person doesn't look good. They're having chest pain. I know this EKG looks fine. And in my mind, I'm thinking, well, I need an old EKG to compare to.
Or a history of old injury.
Right. Wellens sign, this is where you have a biphasic T wave in V1, V2. There may not be in V3, so you'll see these biphasic T waves. You may not see any other obvious ST elevations. This is a proximal LAD lesion. This is called a widowmaker sign, because these patients lose a lot of their left ventricle, so they're hard to get back once they arrest. So they absolutely need stat intervention.
Oh my God.
Right. So
what is going on? It goes away. Right.
This was an EKG I was doing on myself. Trying to see, could I do an EKG on myself after I'd been exercising? And I couldn't.
And you were panting.
Panting and breathing. So so I'm showing this because you get a lot of electrical sway with your respiration. So I'm breathing at whatever, this is per 10 seconds, so at least 2, 3, right? So
24.
Yeah, so I'm breathing at a rate of 24 to 30. Right? It makes, the purpose of this is it shows you how difficult it is to get a quality EKG if things are falling off you. So in this situation, I've been running, I'm sweating, things aren't sticking to me very well. It's hard to get. It's very difficult on our pre-hospital personnel to get an EKG in the back of a moving ambulance with the wires swaying and moving and doing all of this, right? So the fact that the quality of the EKGs are not good isn't necessarily a critique of them. It's a critique of the technology and the problems that exist for them. Again, location EKGs and what their standards are for the positive and negatives are all listed here. The Wilson Central Terminal, that's a collection of these 3 different electrodes acting as a circle and acting as a common point. And then those are related to, the V1 leads are all related to those. This even goes into, like, where do you put the V7, V8, and V9 leads? Right? So I'll make sure that the slides are available. This is from Braunwald saying various tools are available to assess and improve proficiency. This is the website, ecg.bidmc.harvard.edu. So it's just ECG. That's Beth Israel Deaconess Medical Center. So bidmc.harvard.edu.
I think you have it on there.
So that's access to over 490 cases of ECGs. So you can practice this anytime you like. If you're at Disneyland in a long line, break this out.
I would do.
You know, everyone else is sitting there with their little like phones, like doing whatever this little game is. You can do that with your kids, like, you know, like, oh, sucker, that was torsades. You guys suck. You're not getting in the first row. Is that too harsh?
No.
Anyway, I gotta set standards for them. Anyway, here's another website to go to that's a really great website by these Australians, Life in the Fast Lane. So it's litfl.com. They've got great cases, great explanations. It's a really fantastic website, and they cover more than ECG. They started off as just ECG, but now they cover tox and a bunch of other stuff. So it's a great site. I don't know these guys, but they're cool. And then hopefully, you know, we start to realize, for a lot of cardiac issues, there's the phrase, the best medicine is Edison, right? Unstable, like pretty much unstable any arrhythmia, what's the treatment? Shock them, right? So we just have to be ready for that, and that's similar to, this is Gary Larson stuff from Farside. And what's actually interesting is that he's coming out of retirement to do more cartoons again. So, anyway, there you have it.
So earlier when you talked about left and right deviation, and it was PEs,
Right.
ischemia,
Mm-hmm.
what does it look like in the EKG more?
So it's a subtlety here. It's the middle number here in the axis. So you get a report of the P, R, and T wave axis. And so the R wave axis is the middle one. So a right axis deviation from the computer will tell you from plus 90 degrees to 100 plus 150. That's a right axis deviation. Like, in my opinion, it's really like 100, but it's not just my opinion. It's the opinion of a number of other electrophysiologists. But it's more sensitive to say 90. It's just less specific. So from 90 and above is right axis deviation. From minus 30 to minus 90 is left axis deviation. So that's where you see that. And in general, normal is between minus 30 and plus 90, because minus 30 is like this and plus 90 is like this. So your depolarization of the R wave should be going like that. And if it's coming up here, that means it's coming up here because you're missing that. So if you're missing that, that's the infarct, and it's not giving you the signal, right? We're looking for strengths of signal and for the axis of that signal. So this is why it gets difficult with the diagnosis aspect, because you're looking up, you know where the electrical signal should be coming from.
Right.
And then you have it at all these different angles, and so then you have to think about that for a moment, and then you have to think about, well, what happens if the electrical signal is weaker? What happens to all of those different angles? And that's how we define the different regions of this. So if I go back to that regional approach here. If we go back to that regional approach, you appreciate that the 2, 3 AVF are the inferior portion of the heart. 1, because it's over here, left, and V6 are the lateral aspects of the heart, right? The anterior portion of the heart is going to be picked up on V1, V2, not on the limb leads, right? That's going to be V1, V2, V3. That's our anterior portion of our heart. Posterior of the heart would be the inverse of the anterior, so the opposite directions for ST segment depressions in V1 and V2. That's where people flip it, right, to look at it. That could be improved upon by putting 7, 8, and 9 leads on to actually see the ST segment elevation. realizing that that varies, the sensitivity that varies based on body habitus. So the larger your chest is, the further the surface electrode is from the heart. So 7, 8, and 9 may still not be sensitive enough to pick up on that. So you have to kind of balance what you're seeing in front of you with what the EKG is showing. So inferior MIs are 2, 3 AVF. Lateral MIs are 1 left and 6. And then anterior is V1 through V3, and anterolateral will include V5, V4, so on and so forth. That's what those regional assessments are. But you only get that if you're comparing one EKG to another, if you're obtaining serial EKGs, and I won't go into this because we're out of time too much, but this is an article on difficult ECGs in STEMI and lessons learned from serial sampling of pre- and in-hospital ECGs. And the first thing is looking for those hyperacute T waves, looking for what are called the De Winter ST-T complexes. Those are kind of the evolving complexes that we see. And then as you go through from there, being able to recognize Wellens syndrome. All right, these are the MIs that people miss. The left bundle branch block, really finding Scarbosa criteria. And this is how you diagnose a STEMI in a left bundle, is that they have a concordant ST elevation of more than 0.1 millivolts, or they have concordant depressions of greater than 0.1 in V3. There's a whole there's a whole set of criteria for these. Generally, in the left bundle, your ST segments should be discordant from your QRS, meaning they should be opposite. So if they're concordant on the same side as the QRS, that's abnormal with the left bundle. And if they're concordant to 0.1 millivolts or more, that's abnormal. So that's a box. So a box up on the same side as that is abnormal for that. That's Scarbosa. And it's just in one lead. It doesn't have to be in multiple leads, just one for Scarbosa. A lot of people miss that. The concordant depression in my mind, is generally described as appropriate discordance. So ST depression, meaning away from the QRS, discordance, should usually be less than 5 boxes. And if it's less than 20, there's a percentage rule that if it's more than 25% of the total QRS, that's abnormal too. So Scarbosa, like I could do a 20-minute lecture on Scarbosa, so I don't want to do that, but just recognize that there is a way to diagnose it that's specific for left bundle. And then paced rhythms, you've got ways of applying Scarbosa-like criteria to a paced rhythm to pick that up. The posterior MI is misdiagnosed because people don't put on the extra leads and don't interpret V1 and V2 correctly as their ST segments. They're seeing ST segment depression, and they're just thinking it's ischemia when it's an infarct. And then being able to recognize mimics like left ventricular hypertrophy. And then these are ECGs. It goes into difficult ECGs that are missed by automatic algorithms, which are all the ones that we just mentioned. And then that's pretty much it. The major point here was that over and over again that the diagnoses were made based on serial EKGs, not just on one. So it's a blind spot for everybody, and we kind of need to address it. Otherwise, just like in a blind spot in your car, you're going to have accidents. Cool. Any questions? No? All right. Awesome. Thank you.
Very good class. Thank you.
Honda, have I ever shown you